look at the different types of research questions, because many a times the queries which we ask from you all, the queries are regarding research question, how to identify research questions, and what are the different ways you can refine your research question. Then, of course, we are going to look at what are the various study variables and how to identify those variables, what actually is confounding, and how you can handle confounding in your design and also in your analysis phase. This I'm not going to go in great details, but just give you an example. And then the example, the research question which we are dealing with, the ethical issues for such research questions, and the results of the analysis which is done, and how, in short, to write discussion for such a research question. So again, like last time, because I feel the crux of any research is the research question, identifying the correct research question. So we have to ask ourselves whether the answers to our research questions are going to fill any knowledge gap. Are they going to modify or have an impact on clinical practice or on public policy or any program initiative? So if directly or indirectly our research and the answer to our research question does any of this, then I feel that on track. Now, there are different types of research questions. I'm just showing you these types because the type of study design and your decision of the way you want to answer the research question depends upon, like many other things, the research question per se. So there could be a descriptive research question where you will use a descriptive study where you just want to describe the disease in terms of either person, place, time, or all of the three. Or it could be an analytical research question where you have identified specifically the exposure and the outcome, or the independent and the dependent variable, and you are just trying to understand the association between two specific variables. It could be an experimental research question where you want to see the effect of the interventions. Then you have the prognostic type of research questions where you want to see the prognosis of the disease over a period of time. It could be a diagnostic or a screening test research question where you want to assess the validity of a diagnostic or a screening test. Or you want to look at the screening research questions, whether you want to see the impact of the screening program per se on the health outcomes. And lastly, the operational or the implementation research, where you want to find out the barriers and facilitators for interventions in a program, or find out the best possible way for implementing the interventions in a program. So when you frame your research question, automatically there are some preferred research designs which should come in your mind. Again, repeating what we did last time, from where do the research questions come? So it comes from literature, the articles you are reading. Those, while reading, you find that there are gaps or some work needs to be done, so the research question pops up. You can have discussions with experts in a particular field in which you want to do research. That can help you frame your research questions. Then your own experience, you are doing some work and your own experience in the field or in your daily routine. So there are queries which arise in your mind, and that is the origin of a research question. There are call for proposals on the websites of different national, international programs, international agencies. So you can look out for these calls and identify what matches your passion and write your proposals by framing an appropriate research question. And then, of course, each program has its own research priorities. So those are also mentioned by the government on their website, and you can go through those research priorities and identify what interests you. And again, I am harping on this important point that avoid Me Too studies, because many times students come and when we ask them about their research question, their topic of interest, they just narrate the title of some article which they have found during their search. Now, such articles are going to lead to Me Too studies and not going to add in any way to the three dimensions which I told you at the beginning. And therefore, as far as possible, we should avoid replicating studies which have been done multiple times. So today what we are going to do is we are going to look at a specific research question which we try to handle in our electives, the undergraduate elective sessions. So we had two students and we were looking out for research question. The elective was scientific manuscript writing, and Dr. Prashant Huar, associate professor from our department, had already really in our discussion was mentioning this question which was in his mind. It was about air pollution and emergency department visits for acute respiratory illness. So I think we have Dr. Prashant Thowal with us. So basically, he was, or he is rather, a nodal officer for reporting the acute respiratory illness cases which report to the emergency department at JJ Hospital. And I would really like to invite him to tell us about his role and how this particular research question arose in his mind. Dr. Howard, are you here?
Yes, ma'am. Good evening, all.
Yes, sir.
Thank you, ma'am, for giving me the opportunity to share my experience regarding this work. Basically, I was made the nodal officer for this program, and the name of the program was National Program on Climate Change and Human Health. And under this program, Grand Government Medical College and JJ Hospital was made as a sentinel surveillance site for reporting of the cases. So what used to happen that on a monthly basis, as a nodal officer, I used to liaise with the three departments in our hospital, mainly the medicine, pediatrics, and the chest TB department. And the reporting formats were shared with those three departments. Training PPT was also shared with the departments, and they were given a fair enough idea of what will be the inclusions and the exclusion criterias when they report the counts of the cases related to acute respiratory diseases, which they see in the emergency visits. So we had a mechanism of a common Google sheet, and then on a daily basis, the respective departments used to enter the data. And then at the end of the month, we used to compile the data into the reporting formats, which were mainly annexure A, B, C, and D. There were 4 annexures, which we used to fill and report it to the state in Pune, and remaining, and as well as we used to keep them in the loop with the National Center for Disease Control, New Delhi. So this is how the data was started. I came into the picture from 1st of November 2019. And since then, we used to maintain the record of the data in the soft copy as well as the hard copies. And when, as ma'am mentioned, when we wanted to think of the possibility of preparing a research paper, so we had a secondary data with us for last 3 years. So from the year 2020 to 2023. And based on the data, we actually wanted to understand what was the association between the air quality and the emergency department visits in our hospital setup. And accordingly, we analyzed the data for those 3 years, and we got a good insights into the from the data. And this is how it was. This is how the curiosity to understand what is the association between the air AQI and the patient visits. And as we already had the data with us, we thought of carrying out a research paper.
Great. Thank you, sir. The word curiosity, which sir mentioned, I think is very important. So he was doing a job and it was his routine work, but somewhere in his mind, he had a question that whatever numbers he is reporting, how is that really affected by the air quality? And that is why I think the word curiosity is important. Keep your eyes, ears open and keep thinking, and you will get interesting research questions. Thank you very much, Dr. Prashant Huar.
Welcome.
So now next what we did once we knew that this is what we are trying to answer is so again this is actually what kind of a research question. This was a question for you all, but anyways, so because why do you think this is an analytical research question? Anyone from the audience? Because I told you there are different types of research questions. So why do you think this is an analytical research question?
Good evening, ma'am.
Yeah, good
Yes.
evening.
So we are trying to find the association between these two, ma'am. That's why,
Right.
like air pollution and the number of ARI cases. That's
Correct.
why it's called analytical research question. Yes.
Correct.
Thank you.
Right. So there are two variables and we want to see the association between two variables. So it is an analytical research question. So Dr. Howar has already mentioned in detail about the context in which this particular research question arose. So I'm not going to again repeat it, but in summary, the department was already collecting data and reporting the number of cases of acute respiratory illness under a program, and this was being done by the clinical experts in three different departments, the clinicians in three different departments who were reporting to the nodal officer of the hospital, who in turn was reporting the numbers to the district, then the state, and then the data went to the national nodal officers where all the data was accumulated and the report, annual report was published. So that was the flow of the data. So this was about actually the number of acute respiratory illness cases reporting to the emergency department of our hospital. So this is how the reporting was done. So we had three departments and they were reporting. There were different headings under which the reporting was supposed to be done, the details of which I will show later on. But there was an app on which the reporting was or is being done, because it's also currently being done by the departments. So the research question was, is there any association between air pollution and patients with acute respiratory illness presenting to the emergency department? Again, what I want to show is that as we look at the data, as we read literature, the research question, we keep refining the research question and retuning the wordings which are there in the research question. So as Siva mentioned, we are interested in two variables, the outcome variables and the exposure variables. So what are the outcome variables here? The outcome variables, if anyone can, again, because Siva has already said, but let's just be clear about which is which variable.
Acute respiratory illness.
Sorry?
Acute respiratory illness.
Is the right
Outcome.
Yes. So Ashwini says that acute respiratory illness is the outcome variable and the air pollution or the air quality is the exposure variable. Now, actually, when we look at the data, there are some specific headings under which the acute respiratory illness is reported. So it is in terms of the daily total number of patients visiting the emergency department in these three specialities, the total number of patients diagnosed with ARI in the emergency department, the total number of patients receiving nebulization in the emergency department, requiring hospital admissions in the emergency department, and then requiring non-invasive, and there is a sixth one, requiring invasive ventilation in the emergency department. There are 6 different headings outcome. for which data is reported, and these are daily number of cases who are visiting or who are requiring different interventions for management of acute respiratory illness. So what we have to do actually is, once we know what is the outcome, what is the exposure variable, we have to further go and see what is it in the outcome variable that we can collect, what is the feasibility, what is available, what can be done about with respect to the outcome variable. Now, as far as the exposure, so we had data for the outcome variable, but what about the exposure variable? So the program was not really collecting data, or the nodal officers was not collecting or reporting about the exposure, that is air pollution or air quality. So we had to look at some other resource to get data on the exposure variable. So this data was obtained from the Central Pollution Control Board, the website of the board. So the air pollution is measured using the air quality index. So there are different air pollutants, the levels of which are measured, and the 24-hour average concentration is used for coming up with the air quality index. So that there is a formula, and there are different set protocols for calculating air quality index, the values of which can range from 0 to 500. Now here what I'm trying to tell you is, you should know what your outcome variable is, what your exposure variable is, and then from where are you going to get the data, and what will be actually the variable. How are you going to define the variable? So we have now an index which is going to help us measure the air pollution, and this we are going to get from the website of the Central Pollution Control Board. So there is some clarity on the exposure variable. Now when we look at this data now for exposure, and then we try to look at our research question, our research question becomes, for 1 unit increase in the air quality index, what is the change in the number of cases presenting to the emergency department? Now we have to ask ourselves, are we interested in this research question? What is the utility of this research question? So when I look at this research question, I feel that, okay, answering this research question can draw attention for climate change. That is, a unit increase causes so much increase in the number of cases coming to the emergency department. But for the hospital or for the care providers, this does not hold much value, because we hardly look at unit increase, or what is a unit increase or change in the air quality index. So we have to really look at the exposure in more details to refine our research question. So if we look at the website again, this air quality, the indices are classified into different categories. There are the set cutoffs for categorizing the air quality index into good, satisfactory, moderate, poor, very poor, and severe AQI category. So we now look at these categories. We say, okay, we will not look at 1 unit change in AQI. We will look at change in the number of cases coming to the emergency department as the AQI category changes. So it will be easier, even the clinicians or somebody can look up and see what is the category which is there, and we can have a rough idea about the cases which one would expect to have occur on that particular day. So the research question now is with regards to the categories and not 1 unit change. So the question becomes, does the number of ARI cases presenting to the emergency department differ according to AQI categories, or is the number of ARI cases presenting to the emergency department associated with AQI categories? So your research question can have different wordings, and you can refine it until you are satisfied with your research question, because that is the crux of your research. So you can go on refining your research question, and it could be something like, what is the risk of patients presenting with acute respiratory illness to the emergency department of a tertiary care hospital in a metropolitan setting during births or the degraded AQI categories compared to a good AQI category? So that could be your final research question. So as you read, as you look at the variables and the data you have, especially for secondary data, you can go on refining your research question and then be satisfied, okay, this is the question which I want to answer using my data. So are there any questions, Sumana?
Not yet, ma'am.
Okay. So for those who have joined late, we have just repeated some content from the previous presentation where we are really still looking at the research question, how we are identifying the research question, categories. So of course, after the research question has been finalized, you have to think about your primary and secondary objectives. So we want to see the change in the risk of patients reporting with ARI to ED of a tertiary care hospital during worse AQI categories compared to good AQI categories. So you should have a clear objective, and primarily your results should answer this research question, serve this objective, and your discussion should focus on this question and this objective. That is why clarity is important here. Because we have different data on different under different headings in the program, we can say that, okay, I am interested in association between AQI categories and daily numbers of these 6 different heads, but still within them, I may have to identify one point of interest. Say I am primarily interested in number of patients diagnosed with ARI reporting in the emergency department. And the rest of the thing could be my secondary objectives. Now, we know that, okay, my outcome variable is acute respiratory illness. My exposure variables are the AQI category. So for these 2 variables, I should know the definitions. I should know if there are categories, what are the criteria with references that I am making some categories. Then eligibility criteria, whom am I going to include, especially for the outcome, whom I am going to include as a case of ARI, and which are the cases I need to exclude. And then, of course, the source of data. So from where am I going to get my data for the outcome, and from where will the data from exposure be obtained? So we have already discussed all of this, because the source of data, I told you, for the outcome variable is through the surveillance system. For the exposure variable is from the Central Pollution Control Board. There are set criteria for the exposure variable, and I'll show you the eligibility criteria for the outcome variable, which were also laid down in the program. Now, as you are doing this, that is deciding upon your outcome and your exposure variable, you also have to think, like, what are the criteria? Are you using objective standard criteria or not? Because what you're doing here comes up in your discussion later on. So if you are using objective criteria, then you are sure that there is less chance of any selection bias or any misclassification, which becomes a strength of your study. So when I know that, okay, these criteria I'm using for AQI and these are standard criteria, that becomes a strength of my study. There are specific eligibility criteria which are going to be used by the clinicians to identify ARI and report. It becomes a strength of the study, where I will say that because I'm using this criteria, there are less chances of selection misclassification. And then, of course, when I'm saying that the clinicians are reporting, they are trained, they are experts, so there will be less chance of selection bias or misclassification of ARI. And because I am taking data from 2 different systems, that is, one is the hospital data and the other is the website data, they are not linked to each other in any way. So the clinicians who are reporting the numbers are in no way aware of the ARI or the air quality or the air pollution on that day, because they are not aware of the research question. So there is a sort of a masking. So as I'm writing my methodology and I'm doing work around my outcome exposure, I should also think, is there any strength or limitation which I may need to harp upon or to mention in my discussion? Then, of course, the next thing is that When we are answering the research question, especially an analytical research question, we cannot just be interested in these two variables, the outcome variable and the exposure variable. There are other variables which are also important, which we'll talk about later on. So this I have already told you: definition, criteria, category, source. These for outcome and for exposure, you have to mention in your methods section. So the eligibility criteria for ARI was mentioned in the program. So Dr. Howard has shared these details that there were inclusion criteria and exclusion criteria, whom to report as ARI for the program surveillance system. So there was clarity and there were set criteria for inclusion and exclusion of the outcome variable. Then I
Ma'am,
told
we
you
have
that,
a,
yes,
sorry,
yes,
ma'am,
please,
we have a query.
yes.
Does the sampling method depend on our type of research question? Is the research
Yes,
question?
yes. But today we are not going to talk about sampling. I request Dr. Sumana to note down this point. We will take a separate session on sampling.
Yes, ma'am.
Sampling, yes, sampling will be affected by your research question also. So this reporting was done by trained persons, by the clinicians, by the experts. An app was used for daily reporting, and the exposure outcome were for different from different sources. So all these are strengths, but one possible limitation could be: did the availability of resources affect certain decisions like nebulization or the ventilation, non-invasive or invasive ventilation? So were the reporting of those numbers, could that have been affected by availability of resources? So when you're thinking, you have to note this down, and this you may have to mention as a limitation in your study, right? So what I'm trying to tell you is that when you're talking about your exposure and outcome variables, those are also the moments where you're writing a methodology, but also you have to think, okay, is everything right, or are there any loopholes which I have to mention as a limitation in my discussion? So I told you the independent exposure variable. Now this, when you have to read in detail about the air quality index and the categories, this is actually also a web-based system where all the recording is done on a real-time basis. It's an automated system and there is no human intervention. And the details of the AQI, how is the data for the air quality indicator collected, is mentioned in a booklet which is published by CPCB. And this really is important because you need to mention this in your methodology, because this builds a confidence in your data, that the data is objective, there is no human intervention, everything is automated, and the values are put on the dashboard in an automatic fashion. So you have to mention the definition, categories, and the source of this data also in detail. Now, last time I told you, when you have your data, you have to first do a descriptive analysis of your data. So when we looked at the data, what we found that was that there was not, there was no, there were no observations in the severe category where the AQI was 401 or above. So we excluded that category. And there were few numbers in the poor, very poor category. So we clubbed the numbers in those categories. So whatever you do with your, so when the seasons are comparable, then I am comfortable comparing the numbers in different AQI categories. If the seasons are different, right? So you have a good AQI category and you have, it's a summer day, and you have a poor AQI category and it's in the winter, and you are looking at the numbers of acute respiratory infection presenting to EDs. You really don't know whether these numbers differ because of the difference in the AQI, or whether they differ because of the difference in the seasons, right? So you have to be sure that the two groups which you are comparing are comparable with respect to all important variables except the exposure category. And that is what I mean by saying that groups which you are comparing should be comparable. Is there any question here?
No, ma'am.
So you are
No questions
interested
answered.
outcome, exposure in the outcome variable, and you are interested in the association of these two variables. What I'm trying to say is that you cannot just be satisfied with the two variables. You have to look at other variables which are important, and I'll tell you what I mean by important. And you have to be sure that they are comparable, means the distribution is similar in these two groups. So I'll really tell you what I mean by comparable and what I mean by the other important variables in the upcoming slides. So now what we are talking about, all these other important variables, they are known as potential confounders. I'm sure some of you all know the concept of confounding. So I would again invite some of the participants just to share their understanding about confounders and confounding.
Ma'am,
Yes.
confounders are variables that should be directly associated with the exposure variable individually and outcome variable individually, and it should not be in the direct causal pathway.
Yes. So what Dr. Dinesh has mentioned is the classical definition of confounder or confounding. We will really look at first the concept, and then I would also want you to think about what could be the confounders in the association which we are studying. So confounder, actually it means mixing of effects. And I will just give examples. You identify two individuals and you see them together often, and you feel that there is an association between the two individuals. There is a special relation between the two individuals. So you feel, okay, these two individuals are associated with each other, but there is a third individual who is a friend of this person, and these two individuals are frequently observed because these two are association, but there are other associations which are mixing up the effects, and this leads to an incorrect effect estimate. So confounding is a situation where an association between an exposure and an outcome variable is either partially or totally or entirely due to another exposure, which we call as a confounder. So I've already told you that, okay, we feel A and B are associated with each other, but actually B and C are associated with each other, and A is more associated with C than B, and therefore, when we have a look at the associations, we feel that A and B are associated with each other, which is a wrong understanding. So, in a simpler way, confounding, there are different definitions and different ways you can understand confounding. Every person is comfortable with a different understanding. One understanding is that one variable mixes, there is a mixing of effects. There are two associations, and those are mixing with each other. That is confounding. Another way of understanding confounding is an alternative explanation for the association. A and B appear to be associated, but I have an alternative explanation that C has a role in this association. So if you have alternative explanations for any association, it means there is confounding. And then, of course, when the effects of two exposures have not been considered separately, just read this out and then explain. And the two exposures are associated. So again, mixing of effects. So there are two exposures, and those are simultaneously affecting the outcome. You have not separated out the effects of these two exposures. Then there is mixing of effect, and that leads to confounding. So these two are different ways of understanding confounding. The third one, of course, is what Dr. Dinesh mentioned. That is, you have to have a variable. You are interested in the exposure and the outcome, but is there a variable which is associated with the exposure? That is, it occurs more likely with the exposure. The exposure is present, more likely that this variable is also present. This variable is also an independent risk factor for the outcome. It is known that it is a risk factor for the outcome. And the third criteria to say that the variable is a confounder is that it should not be on the causal chain from the exposure to the outcome. So, Sumana,
Yes,
I
ma'am.
don't know because I'm getting different requests for recording. I don't know who is recording actually. So I think you
No,
can
ma'am.
just all kinds of recording then.
No, ma'am. I am only recording. I apologize. My internet was breaking, so that's
But
why.
I just, yeah, okay. Just check it out, huh?
Yes, ma'am.
Yeah. So the variable of interest, this
Ma'am.
variable of interest is actually, I'm repeating, is associated with the exposure. It is an independent risk factor for the outcome, and it is not on the causal chain. That is, A causes B, but it causes it through the C, which is a
वो भी कर सकती है क्या?
which is a
Excuse me, ma'am.
yes.
Ma'am, actually, that the the request that I sent you, I think it has been opened for all the recording request. So that is why maybe you are getting that option.
Uh-huh. So just then we will not record it, no, just close all the recordings. Can that be done?
Yes, ma'am. Can you please, ma'am, make me the host? I'll disable that.
Yeah.
Very sorry for the interruption.
Sorry, ma'am. I had got a call. Was that the problem?
No, not at all, ma'am, not at all.
I cannot even attend a webinar, madam. I keep getting calls. I had to log out and now I'm logging in
No,
again.
ma'am. No, it's not
I thought
any.
my call
What?
was heard or something.
No,
Because I
ma'am.
could hear both. That is why I was surprised. I could hear the caller also speaking to me and I could hear you also. Both simultaneously I was hearing.
No, ma'am. It's not fault at your end.
Okay. Yes.
Yeah. Sumana, I have made you the host. So please disable
Yes,
all
ma'am.
recording. Yeah.
Yes,
So
ma'am.
we
I
will
will
not
do that.
record this session. No
Yes, ma'am. I
issues.
will
No,
do that.
we will record. Yeah. Steps. The first.
This
So
is
again,
me, ma'am. No, ma'am.
okay.
I have disabled that thing. This is just
Okay.
recording in my computer.
Okay. So the first step is to identify potential confounders. In your method section, you will write, see, these are the potential confounders I am worried about with reasons and with rationale. Why are you thinking they are potential confounders? The second thing to do is to collect data on potential confounders. You cannot just say, okay, these are confounders and leave it at that point. You will have to collect data and you will have to control for these variables either in the design or the analysis phase because you want to understand the pure relationship between exposure and the outcome after cutting out the mixing which is occurring. So you want to see separately after adjusting for the confounder what is the relationship between exposure and the outcome, and then you interpret the results and you say what happens when you address this confounding and how you have addressed the confounding effectively in your discussion. So the first step is identifying potential confounders. So the attempt here is to understand what is confounding. Once you understand that, then it will be easy for you to identify the confounding variables for your study. So what are the different ways you can think of potential confounders? Now, the easiest way is think about biological plausible risk factors for the disease, right? So focus on your outcome and you say, try to find out what all could be the risk factor for the disease. That could be the first step. And then as I give you an example. Ask yourself whether how many of these are associated with the exposure and not on the causal pathway. Those are your confounders. Another step or another method of finding out confounders is what is known as directed acyclic graphs. So these are causal diagrams. The diagram which I showed you for confounding for the classical definition is an example of DAGs. So these diagrams are graphical representation of causal structures of the causal linkages, which give you clarity about what your exposure is, what your outcome is, what are other variables important for this relationship, and which of these variables could be confounders. So this is again a very interesting and a separate topic, DAGs, which are used in a very big way nowadays. But this gives clarity to your research question. The third is reviewing literature. So you will read articles on your topic, and when you're reading your articles, you will find out that there are various risk factors or predictors for your outcome or directly mention of confounders, which you will have to include in your study. And then the last, of course, important option is to discuss with the experts and ask them, if I am studying this association, if I find an association, do you think there could be any alternative explanation for this association? Sumana, I'll just remind you that we need to take a feedback because might be some people are busy and they might leave because it's now 1 hour that we have started our session.
I shall post the link already, ma'am, if anybody plans to
Yes.
leave.
Yes. So this particular slide is actually what it is telling us is what are the methods to identify confounders? Once you understand confounders, okay, there are but various ways in which you can identify confounding variables. So we have already tried and answered this question. If you have any more answers, you can put it in the chat about apart from season, humidity, temperature, the other list of confounders you mentioned, you may have by now thought of some other variables which are potential confounders. So you have to make a list of all the potential confounders. So there was some, when we looked at literature, we found that there was some other, like you mentioned about temperature, humidity, but some studies also mentioned holidays. That is, they have taken each day as a working day or a holiday. And this is also very interesting because on a holiday, say the traffic is less, so the air pollution is less. On holidays, people might get time. Like even if they have severe illness on a working day, they might not be able to visit the emergency department, or they may not have somebody to accompany them to the emergency department. It may be more feasible to go to the department. So this is a very interesting variable which we found when we were reading articles on this outcome. So this becomes a potential confounder. That is whether it's a holiday or a working day. Because how is it a potential confounder? Could anyone explain? I've already tried to do it, but if anybody could repeat it, that would be great. Why am I saying that holiday or working day is a confounder for the association between AQI and ARI?
I have a doubt in this question, ma'am. The same holidays,
Yes.
it actually positively is associated with the ARI, whereas it's negatively associated with the exposure
Yes.
in holidays. So, should we call it as confounder? Is it right, ma'am?
Yes. See, the very interesting question. This association need not be positive, positive. It can be
Okay.
positive, negative, 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 positive, negative, all kinds.
Okay.
The only thing is there should be an association.
Okay. Okay, ma'am.
Yeah.
Ma'am, I have, but can we have that like um, the positive association for hello?
Yes, yes, please. Yes, Dinesh.
Ma'am. So it's a negative association for air quality index and the positive association for the
Yeah.
cases to get reported.
Yes.
Uh, will that be the effects will be different, ma'am? So should we have that as a confounder, ma'am? Should we
Yes.
account for?
We should have it. See, anything. We are not saying they should be associated in a similar fashion, right? It's only an association. That is, this variable is a risk factor or it is associated, it will affect your outcome in some way. it will affect or it's associated with the exposure in some way. It need not be in the same direction.
Okay, thank you.
Yeah. So I think the way you have asked questions, I feel at least some of you all have a clarity why we chose holidays as a potential confounder. Because whether it's a holiday or working day, the decision and the care seeking will be affected in the emergency department, and the air quality might be affected. And holidays, whether the ARI, sometimes it may affect whether it's a holiday or whether it's a working day. Again, this is very tricky. For example, when I was in Delhi, the ARI did affect the declaration of holidays. There were days when people were allowed to work from home, etc. So this is tricky, but you will have to really look at this from a very critical angle. The next thing is, again, what we did with the exposure outcome. For a confounding variable also, we'll have to define, categorize, and find sources of data for our confounders. So for seasons, now for this association which we are going to analyze, we have just taken seasons as a potential confounder. And we have again referred to literature, and we have said that according to the months, we are going to categorize the months, the days into different seasons. So March to May, we considered as summer, June to September as monsoon, and October to February as winter seasons. So this again will come in your methodology, that these are our confounders. This is how we define and categorize our confounding variables, right? So ethics for this data, actually this is secondary data. There is no individual level data we have collected. It's all de-identified data. The pollution data is available in the public domain. So for such kind of research, you won't require any approval from any ethics or ethical committee. So once we are clear about, okay, these are my variables of interest, you now have to extract the data from the respective resources, do data entry, and properly manage your data to ensure that there are no mistakes and there is no missing data. So when we did that, this is the kind of sheet we got. So we have the different dates. Then we have the number of cases coming to the emergencies, ARI, requiring nebulization, requiring admission, requiring non-invasive, invasive ventilation. From the Central Pollution Control Board website, daily we extracted data for the AQI, the value of AQI. We know the cutoffs for the AQI category, so we categorize them accordingly. And then we looked at the date, the month, and we also created variables for the different seasons. So you can see that there are numbers from the program. There are numbers which are converted into categories, and the dates which are converted into, again, some categories. So somewhere you get ready-made data, and somewhere you have to do recoding and create your subgroups. So this is what is the data which you will then take up for your analysis. Any questions here?
Madam, I have a question.
Yes.
Like AQI would be different in different parts, even of Mumbai. I mean, so AQI, if you see, like even the temperature for that matter now in Mumbai, it is different in the coastal areas. It is different in the center. Similarly, AQI is different in different areas. So, which AQI? I mean, which AQI are we referring to? I mean, when we extracted the AQI data.
Yes.
So which area or which locations AQI we took into consideration?
Yes, you are right, madam, that AQIs, there are different stations within a city, and the stations record different values for AQI. What we have taken is the average for the city. So what CPCB does is it collects data from all the different stations, and it also has the average data for the city. So what we have extracted is for Mumbai per se. So this is the average for Mumbai. Again,
Okay.
what mentioning is very interesting. All of this has to be mentioned in the discussion as a limitation. So again, we are assuming that people who came are all residents of Mumbai.
Of Mumbai, yeah.
People have traveled and they have come from outside. So these
Yeah.
are limitations which we should mention in our discussion section.
So there would be patients even from Thane, for that matter, from Navi Mumbai also. So they would come under Peri-Mumbai and Peri-Mumbai areas. So again, then we would have patients coming from there, but the data collected would be from Mumbai.
So all this has to come up in the discussion section as a limitation. First, you will have to check the AQI is for what geographic region, and then you will have to check, okay, this hospital caters to what geographic region. If there is a mismatch, you will have to mention that in your discussion section.
Okay, ma'am. Okay. Thank you, ma'am.
Right. So the next thing, now you have your data in your Excel sheet. Again, in the last session, last class, we said that do not jump to your regression and answering your research question. We are always excited and in a hurry to do that. But the first thing to do is to understand the data. And for that, you need to do your descriptive analysis. Descriptive statistics need to be used. Try to understand the distribution of the exposure variable, the outcome variable, as well as the confounders. And you summarize your data for these variables. For example, for the AQI, ARI, because they are numbers, you can talk in terms of median and interquartile range because they do not really follow a normal distribution. If they are categories, then you can summarize the data as frequency and percentage. You can summarize in the text or in a table or even graphical form like the box and the whiskers plots for non-normal data, which is usually used. Or you can have cross tabs, and in the tabular form also you can try and report the results of this kind of analysis. So when we looked at the data and did a descriptive analysis for the exposure outcome variable, we found that this was the distribution for the AQI. Now we are not looking at AQI categories, we are reporting just AQI values and trying to understand what was the situation. So you can see that the data we have looked at is from March 2020 to December 2022, because this was the period our department was actively involved, and from later on, many of the departments are really putting in more effort and directly putting in the data in the app. So we have data for 1036 days. The median AQI for these days was 83. The interquartile range was 58 to 152. And for the 24th of January, we had an outlier, which is the AQI of 381. So this is the box and whiskers plot. This is the outlier, the dot which is there. This box which is there is the interquartile range. That is the lower horizontal line of the box is the Q1. The middle line which is there here is the median or the Q2. The top line of the rectangle is what is known as the third quarter. And the whiskers, the lower line is, and the upper line, these are known as the whiskers, right? And then you have the outlier. Now the outlier, anyone knows what the outlier means? Because I think I'll just, we are really running a bit late. I'll skip because I wanted to really discuss box and whiskers plot, but this I think we'll keep another session for the graphical presentation. So I'll just skip this, but just the take-home messages, you can use graphs to summarize your data to and understand what is the distribution of AQI. So for the study period, what was the range in which the AQI was spread and what was the average or the central value is what this graph tells us. Similarly, we also look at the distribution of the ARI cases. So again, for the different headings under which the reporting was done, we have the median value. So what this data is telling us is that the median number of cases presenting to these three departments was 43 cases in the study period. 16 cases with acute respiratory illness per day, 7 requiring nebulization, a median of 6 requiring admission, 2 requiring non-invasive ventilation, and I think it's 1 requiring invasive ventilation. So my summary gives me a sense of the numbers I am working with. What are the averages or the medians, and what is the distribution of the data. Here too, you see that there are positive outliers under each heading. So my summarization of the data is helping me with understanding my data. The third thing I do is now I put both of these together. That is, for different AQI categories, what are the median and the interquartile range for each of the outcomes? So what do I see here? Can anyone just describe the table? What are you seeing here? This is still descriptive statistics. I'm trying to see the distribution now together. I'm not applying any test here. I'm just seeing what is the distribution of the number of patients coming to the emergency department for different interventions according to the AQI categories. So what I see is that the average daily number of patients reporting to the emergency department, when the AQI is good, the median number is 48. When it's poor, very poor, it's 44. So this is a bit surprising. What next do I see? With respect to the ARI cases reporting to emergency department, can anyone describe? I'm talking about the third column.
May I?
Yes, please.
So specifically for the third column, it is very clear that as the AQI is getting worsened, the number of cases, in this case, we have used median as the descriptive way. It is also increasing. The number of patients coming to the emergency department is increasing as AQI is getting worse or
Yes, so
poor.
it was 13, it became 16.
16, 16. No, it is actually, it is very similar, except for good rest is very similar.
Yes, for the rest it's similar, but we are always going to compare with the good. And because we are dealing with the median, right? So there are a bit issues because we are not looking, it's not a normal distribution, it's a skewed distribution. So the median still may not tell us the right picture, but we are just trying to get a judgment, right? It's not a complete picture of the distribution. These are skewed distribution. The median, what we saw in the viscous plot also, that both the outcome and the exposure, there are outliers. So this is just a rough idea of what is happening. This is not the final distribution or the end of the story. Okay. So this is just a rough idea of what is happening as the AQI categories worsen. Similarly,
Ma'am,
for nebulization. Yes, please.
ma'am, as you are mentioning, since in this particular example, specifically median is used, but in general, people see mean. So, could you just shed light on that part that
Yes, yes. See, we are looking at number of patients, the outcome. The outcome is number of patients who are presenting to the emergency department. Now, we have this for 1036 days. Now, these numbers, we are always looking at the outcome data, whether it follows a normal distribution, whether it is skewed. All the criteria which we are going to use for further analysis is based on the type of data for the outcome variable. Now, these numbers are not going to follow a normal distribution. So there is no sense in summarizing the data using mean and standard deviation. The other alternative we have is median and interquartile range. So this is just giving a rough idea about, because we don't want to blindly go into regression. So we want to get a sense, okay, what is happening? So as the AQI categories are going from good to worse, patients requiring nebulization is increasing. There is not much of a difference for satisfactory, moderate, poor, very poor. For good, it is less, but it increase, the number increases from satisfactory itself. There is no, it doesn't appear to affect much the number of patients requiring admission. There is a slight increase for non-invasive ventilation. So a rough judgment of what is happening to the numbers with the with respect to median and interquartile range is what such a table will tell you. So you do not want to blindly go, because the regression is not going to give you such numbers. It is going to pop up the incidence rates directly. So just to get, we have to report such table across exposure categories. I hope all of you will get. So as we move forward,
Let be affected on the same day, no, ma'am. They might get affected 3 or 4 days later,
yes,
and so that they can present to the OPD on a good AQI day.
correct. Yes,
So
yes.
that might affect our result, no, ma'am. So how do we account for that? Or should we take the correlation instead of association, ma'am? How does
So
it
question
like how does the difference?
you have
Uh,
raised is a very interesting question, because again, the
yeah.
the way to answer that question is known as the lagged effect. So in the model itself,
Okay,
you
ma'am.
have to include the lagged effect which can be done. So again, remember, there are studies which look at lagged effects, and because now I am not using lagged effect come up in my discussion as a limitation.
Okay.
Because we have done analysis of lagged effect, we did not see any difference
Okay.
for on the day and the lagged effect. So we have stuck to on the day of the AQI category per se. But there are techniques by which you can see the lagged effect. So you will say today is a bad, very poor, or very poor category. What happens on this day, the next day, the second, third, fourth? This you can have a lag up to as many days as you want. Or you could take the average of some days and look at the effect of the average AQI over a span of say 1 week. How does that affect? So everything depends upon your research question. So if your question
Yeah.
is to study the lagged effect, you will include the lag variable in your model.
Okay, ma'am. Okay, ma'am. Thank you so much, ma'am.
Yes, yes.
Adam, can this be done for a season? Like, we say that the best, like, we have studies like this in tuberculosis. That's why, and this lagged effect was brought up because we see that, even when we looked at our data, so generally, rainy seasons are the best AQI, rainy season is the best AQI kind of season. So subsequently, in the months of October, November, December, we had lesser patients coming with tuberculosis. So,
Yes.
as he was saying, so the best seasons are from July to August, June, July, August, and then or September, and then we have lesser patients coming subsequent. So that was also one thing. But then we are not looking at lag, but whether we could have seasonal look at it, maybe later, whether we could have had seasonal look at it.
Yes. So lagged effect can also be done for days. It can be done for months, for any period we want. That is, when we say that we are not interested on the immediate effect, but delayed effect. So that we say there is a lag between the exposure and the outcome. I feel that the AQI category today will result in symptoms or presentation to the emergency department after 1 day, 2 day, after some days, then I will have to look at the lag effect. Similarly, for the question raised by you, if you feel that the lag can be for a longer period, say months, you can include that sort of a lag in your model to answer your research question. But these are very interesting questions, and studies like this are there in literature and can then come up with appropriate method to answer that question. So what is your research question? We did try and understand what is the lag effect. We did not see any difference between the effect on the day, subsequent days. So we decided to keep Dr. Siva are very, very pertinent and interesting. Then, of course, we also look at the AQI categories according to, because now I have my confounder. I have to see how things are changing according to the confounder variable. So I look at AQI categories according to the different seasons to see that I was thinking they would have been different. Are they different? Yes, you can see that the AQI categories differ according to the seasons. I'll go a bit fast. If you have any queries or if you want me to go still slow, you can indicate it to Sumana. Then I look at the distribution of ARI according to season. So this confounding variable is important. I need to see what is the distribution of the exposure according to the confounder, what is the distribution of the outcome according to the confounder, if they are changing as I had assumed they would change. And that's the reason why I took it up as a confounder. So again, you can see here that all these different numbers under different heads appear to be different for different seasons. So seasons appears to be an important confounder for this association. Again, I am summarizing these numbers according to the type of data. It is median and interquartile range. Once I describe my data, okay, I say that this is the distribution of my exposure outcome, this is the distribution of my confounding variable, and this is the distribution of the exposure and outcome in different categories of the confounding variable. And I show that, okay, for my data, this is a confounder. When everything is clear, then I go to my inferential statistics. And like last time, I have told you that you may need to consult a statistician to answer your research questionnaire, to test your hypothesis and use appropriate tests of significance. Confounding, handling confounding, you can say a priori that no matter what happens in my data, seasons I am going to take as a confounder, or I may use some analysis like stratified analysis or stepwise regression, some statistical technique. See, there is no statistical test to identify confounding. It's by eyeballing, by comparing, without using tests that you will have to take a decision about whether to include a confounding in your regression analysis. So you can have a priori confounders. Many confounders could be decided based upon the type of data and your preliminary analysis. So in this data, I have done the negative binomial regression like last time, because this is count data. For a fixed period, my unit of study is 1 day. 1 day, what is the count of patients that allows me to look at it either as a Poisson or a negative binomial. And because my exposure variable has different categories, I have to also mention my methodology, which is my reference category or baseline. So this is an ordinal variable. So the good AQI category, I declare that this is my reference category. And I'm going to compare the numbers for all other categories with respect to this baseline or reference category. So this is all a part of your methods section. Why you have chosen, what is the rationale for the kind of analysis you are going to do, and what is going to be compared with what has to be declared in your methods section.
Ma'am, I have a doubt.
Yes, please.
Ma'am, we actually handle confounding in analysis and before analysis also. While
Yes.
in this particular study, before analysis, what can be done, ma'am? Like to address confounding.
Yeah, I'll come to that point towards the end actually, because what Ashwini is saying is very important. That is, we try to handle confounding either in the design or in the analysis. Now, for this kind, what are the options you have for the design? Can you tell me, Ashwini, what are the ways you can handle confounding in the design phase?
Ma'am, usually we do randomization,
Right,
matching,
right,
restriction.
right. So here, what do you think? Randomization? I don't think so it's possible, right?
Yes,
Matching,
ma'am.
we won't do because we have 1036. If we start matching means what would you match? You would match for seasons. So I will
Yes.
have to take data if for poor AQI category, right? So there are 3 seasons. Again, matching for 3 seasons would make it very, very complex and you would lose data, right? You will not be able to use all your data.
Yes, ma'am.
That will affect your power. Restriction
Yes.
means that again I am going to lose on data. I will say I am only interested in the AQI categories for winter season. Might be in winter season, I will not have any good AQI category at all. So again, restriction is also problematic. I am using secondary data. So for secondary data, usually not much can be done in the design phase. You will have to do and handle all of your confounding in your analysis phase. In your analysis phase, what are the options you have? One is stratified analysis, right?
And
Another standardization,
adjustment.
yes, and adjustment using regression. So we have used regression.
Understood.
Yeah. Again, regression depends, the type of regression depends upon your outcome data. Each regression requires certain assumptions to be met, need to be checked, and then you need to consult a statistician or some expert to decide what kind of regression you will do. So when you do a regression, you get, now this again is a very busy table. I don't know whether I should have taken all the 6 outcomes or just restricted to one, because you can just choose any one outcome and we'll just focus on that, because this is the will actually come in the result section. So anyone can just pick up any of these results for any column, any outcome, specific outcome. So say we, as I said, if we are primarily interested in the number of ARI cases reporting to emergency department, compared to the number, because now we are using regression, the regression which I am using is going to tell me it is an incidence rate ratio, right? So this is going to tell me the rate or the risk of the patient who comes to the emergency department compared to a good AQI category. So compared to days on which there is good AQI, the risk of the patients presenting to the emergency department on satisfactory AQI days is 13% more, 8% more for moderate AQI, and 19% more for very and very poor AQI, and these are statistically significant. So there is a significant increase in the number of patients or the risk or the incidence of ARI coming to the emergency in the emergency department, and by this percent. This is how you will interpret your regression results. Now this is a bivariate regression. I have not adjusted for seasons or confounding here. I'm just looking at two variables, the exposure and the outcome. So this is a crude incidence rate ratio. I'm not adjusting for seasons. So in your results, you first have to show the unadjusted values. So when I'm not doing an adjustment, what are the results? Are you with me here? So I don't want to go into the details of how things are done, but at least the interpretation of the association between the two. When I'm not adjusting, what are the values I am getting, right? This is the first part of the regression you need to show. That is a bivariate regression. And the next thing you do is you adjust for the season. So this is the table which actually answers your research question. It gives you a pure association between AQI categories and the number of ARI patients visiting the emergency department. So can you think of, say, requiring admission? Can anyone interpret this, the one I have circled? An IRR of 1.22. How would you interpret this result?
Ma'am,
Yes.
when AQI categories are poor and very poor, there is a 22% higher risk of patients who are getting admitted on those days
Correct. Compared to
the good AQI category days,
correct. Adjusted for.
adjusted for the seasonality.
Yes. So this is the statement which should come up in your results. That is, after I have adjusted for the confounders, then compared to my baseline or the reference category, what is the risk ratio in the different exposure categories of interest? That is one point to consider. Another point is, if you are also wanting to have a look at, in my data set, what is the level of confounding seasons have cost. So if you are interested in that, the step you have to take is compare your crude and your adjusted incidence rate ratios. So for example, here it was 1.09. The crude IRR was 1.09, not adjusted for seasons. The adjusted IRR was 1.22. So when you see any change happening in the effect estimate, it means there is confounding by the variable which you have adjusted for. Usually it is said if this change is 10 to 20%. So are you getting this? That is, usually we don't your research session, you will only say that I have adjusted for confound association. So you are interested to know, okay, I assume this was a confounder. I want to check whether it's a confounding. I can compare my bivariate value, estimate value with my adjusted value. If there is a change there, it hints at yes, seasons are having a confounding effect on your association. So for each of these incidence rate ratios, you will have to interpret the incidence rate ratios, and there could be some surprising results which you will have to explain in your discussion section, for which literature may help you out. Otherwise, you will have to look at the pattern and overall, you will have to try to describe your findings. For example, you could say that the risk of requiring non-invasive ventilation for poor and very poor AQI days compared to good AQI days is 2.34 times more after adjusting for seasons. So each of these IRR values can be interpreted in this particular way. So this next slide is talking about drawing inferences based on your results, the estimates which you are getting. So the sentence which you will write is what I have just written on the slide, which Dr. Dinesh has already narrated correctly. So I will not repeat it here. Now, some of the participants have asked me then how to think about an impressive title. So we also had a lot of discussion about title of our study. I will talk about the title after again asking you all, do you have any questions till now? Because what we did, again, I'll just summarize. We've discussed about our outcome. What is our outcome? What could be the different confounders? Now, I have just, for example, for the example's sake in this session, I've just taken one confounder, and I assumed, or I thought that, okay, I can't do anything in my methods or the method section, design section. So let me handle this confounder in my analysis. And I have used regression to handle the confounding effect of season. So you have to include your outcome variable, exposure variable, and the confounder in your regression to adjust your estimate for the confounding effect. So regression is a technique to handle confounding. I'm sure this much you all have understood.
Yes, ma'am.
Yeah. So the title we thought was Association between Air Quality Index and Emergency Department Visits for ARI in a Tertiary Care Hospital in Mumbai, or the effect of ambient air quality on emergency visits for ARI, a hospital-based study from Mumbai. So whatever you do, you try and include both the exposure outcome and type of the study which you are doing in your title. When I'm writing my discussion, I begin my discussion by reporting the key findings of my study, on mentioning the strengths and the limitations of the study, which are some of which I've already mentioned earlier. Limitations, one interesting limitation was that this was COVID-19 period. So we had to write a paragraph about how this period, the pandemic period, could have influenced our research question, and the findings, whether they are generalizable to the non-pandemic periods. Also, we have looked at only one site. So what is the question of generalizability is there. We have not looked at other confounders. We have just looked at seasons, lag effect, which was mentioned by Siva. Then we have taken the average of the entire city. So again, you could include that in the limitation. Then patients coming from outside the drainage area for the hospital, that can be a limitation. So all that should come in the discussion section. Another important aspect for the discussion section is implications of your findings. So one implication is, of course, from the point of view of climate change, and then hospital preparedness. This again is very tricky because it's, if we know that, okay, today we have a poor air quality, and if there is literature which says that poor air quality lasts so long, if we assume that it's going to last longer in the future, then this concept of preparedness will come into picture, and this will all require references in your discussion section. Why are you saying about preparedness when the AQI, you know about the category after it has happened? So all these things will come in your discussion section.
Ma'am, I want to ask a question.
Yes, ma'am.
If there are too many confounders in a study, is it really a good study then?
Yes.
I mean, there are so many confounders, and how will we keep explaining?
Yeah. So you can think of the main confounders. If you have large data, now having as many confounders is possible and needs to be done if you have sufficient data, that is sufficient sample size. More variables you enter in your model, more sample size is required. So if you have sufficient sample size, you can have more confounders. If you feel that you cannot include all the confounders, you have limited sample size, you will have to prioritize a limited number of confounders. But in your discussion section, you will say, see, I know there are other confounders, and those are unmeasured confounders in your study. So that is a limitation of your study, that there were 10 confounders, I have taken only 3, 5. I know these are other confounders which I need to measure, but then I say they are unmeasured confounders.
Okay.
Yeah. So what I'm trying to say is, if you know that what are the strengths, limitations, that should not stop you from doing the study. You could always be very transparent and mention all these things in the discussion, that we know that this needs to be done, but we have not done it, and that is a limitation. Now, there were a few queries. Before I go to these queries, if there are any questions, I'll answer those questions, and then I'll go to the queries which were there in our registration form. What we have seen is again a research question, an analytical research question talking about exposure outcomes. And then we have really focused on a small aspect of confounding, that is identifying concept of confounding, identify confounding, and then handling confounding through regression. That much only is what we have actually done. So one question which was there was, while publishing a study, is it always necessary to do multi-logistic regression to confirm association, or can we conclude it using binary logistic regression? One of the participants, any one of the participants should answer this question. How would you answer this question? Do you think multiple logistic regression is necessary, or should we be satisfied with binary?
We should do multi-logistic regression, ma'am, because without accounting for the confounding effect, we cannot say that both interested variables are associated with each other. Absolutely
right. So if you feel that confounding is there, you will have to handle confounding, and one method is regression. So you will have to do it. Then the another suggestion was sharing real examples. So the entire session was based on the real example which we took up. Then the next question was, will the case control study design benefit in studies with confounding? Again, if anyone could answer, because in a case control study, you always talk of matching. So matching is an option in your design phase, which is possible for your case control study. But confounding, you do not always need to do a case control study, right? So you can adjust and handle confounding in all kinds of study designs. There are some special methods like matching. If you do matching in your design, you will have to undertake special analysis in your inferential statistics. You cannot do simple analysis. That is something which you should consider when you do matching. There was just a mention of thesis. I didn't understand what this meant really, but if there is more clarity, we will come up with topics for future sessions. Then there was a very interesting question, which was I had a topic for research where I wanted to study the prevalence of anemia and hypothyroid patients and association with cognitive function. Since cognitive function is a confounder, how do I go about this research? Now, this question was from Dr. Priyanka from IGMC, Nagpur. I don't know whether she's there because many have left. We have only 20 participants.
She's here, ma'am. She's in the
Present,
call.
ma'am. I'm here.
Yeah, very great. Then, yes. So if you just tell us a little bit more about what you want to do, we will discuss your question because we have 10 minutes. Yes, Dr. Priyanka.
Yes, ma'am. Actually, I wanted to do this research as a topic for my paper presentation. But then they said that both anemia and hypothyroidism both are individually causing cognitive function. Therefore, it's a confounder and you cannot go about this topic. So I just then I changed it to just the impact of hemoglobin levels, that is anemia, on cognitive function in adults. But if I wanted to include like both anemia, hypothyroidism, and cognitive function, is there any way I can do this research, ma'am? Like without it being a confounder?
I found this to be a very interesting question which you have raised. See, that season thing, just forget that. Now, your outcome is anemia, right? And your exposure is hypothyroidism, right? Thyroid levels. And now you are saying cognitive function is your confounder, right? So,
Yes.
why would you say cognitive function is a confounder? Now we understand the concept of confounder. So why would you say cognitive function is a confounder with that understanding?
Ma'am,
So
because
yes, yes,
hypothyroidism also causes like cognitive function. And
Mhm.
then even anemic patients whose hemoglobin is low, that also has been in articles I saw references. It also causes impact on the cognitive function.
Great. See, what you will now think is that one is impaired cognitive function an alternative explanation for the association of hypothyroidism and anemia? If I say that hypothyroidism increases the risk of anemia, will someone come and say it's not hypothyroidism, it's impaired cognitive function which causes anemia? Another way of thinking is impaired cognitive function causes or increases the risk of anemia. Impaired cognitive function will impair medication, compliance to medication probably, right? Or memory, and it may impair certain kinds of behavior or treatment seeking. So that will increase the risk of anemia. Hypothyroidism can affect cognitive function. And is cognitive function on the causal link between hypothyroidism? And if your answer is no, then cognitive function is a confounder. Okay. This is one scenario I'm saying.
Yes, ma'am.
So if you say in this context, cognitive function is a confounder. Now what happens? Look at this. What happens if I say hypothyroidism affects cognitive function and impaired cognitive function through impaired dietary intake, impaired compliance to treatment, impaired treatment seeking increases the risk of anemia? What happens? This cognitive function comes in the causal pathway of hypothyroidism to anemia. Do you agree?
Yes, ma'am.
Right. So there could be other ways in which hypothyroidism causes anemia, but it could also impair cognitive function. Now you have to ask the context is more realistic. The confounding one or this is known as a mediator. Now this variable, no, which comes in the pathway is known as a mediator.
Okay,
So
ma'am.
do you think cognitive function is a confounder, or is cognitive function a mediator? Now, this is the reason why these studies, no, epidemiologists, if we have a medical background, this is the reason why we are better in epidemiology, because we know the causal pathways, the biochemistry, physiology, the pathology which happens. So, is cognitive function a confounder, or is it a mediator? What do you say?
Mediator, ma'am.
Yes. So, even impaired cognitive function or cognitive function is in the appears to be somewhere in the causative pathway, so it is a mediator. So
Yes.
there is a special kind of analysis known as mediation analysis, which helps you to see how much of this linkage is through cognitive function. So you see the association between hypothyroidism, anemia, association between hypothyroidism, cognitive function, anemia. But one thing you should remember is that you are always thinking of the causal effect, that you are saying hypothyroidism causes, right? And you know the criteria of causation. So all that comes here, that hypothyroidism should cause impaired cognition should cause anemia. You should have evidence that all this happens, and it's all biologically plausible. And then you say, I feel this is a mediator, and you should go in for mediation analysis. If you include cognitive function as a confounder, what will happen? What will happen, you feel? You
I
will
feel the study won't be like valid because any one of them could be the reason.
you will make a grave mistake actually, because what you will do is you will adjust and you will make the two comparable with respect to cognitive function, and that will force the exposure to become similar, right?
Yes, ma'am.
And that will result in an underestimation of the estimate or the effect of hypothyroidism on anemia. So you should avoid using cognitive function as a confounder. Better read up mediation analysis if you still want to do it, that is, right?
Yes.
And if you
Okay.
don't include cognitive function at all and just study the association between hypothyroidism and anemia, that is fair enough.
Okay, ma'am.
And you do there could be several other mechanisms also through which this association can be explained. But I found this question to be very, very interesting, and thank you for this question actually.
Thank you, ma'am. Thank you.
So Ashwini has already brought up this topic, that how to control confounding in the design phase and in the analysis phase. So how to go about restriction means what? I'll just look at one, cognitive function matching. Now this I came up with this question which she raised. So you can you do it in either ways when you actually want to do a primary study. And usually there are a priori confounders. The most common one is age and sex. So when you're looking at hypothyroidism anemia, Dr. Priyanka, you need
Yes.
to consider age and sex as confounders. Can you just explain how and why would you take age and sex as confounders?
Because one is that mostly hypothyroidism is found in females, and then so is anemia.
Yes.
And then age-wise also, it is seen in the middle age group. Hypothyroidism, the incidence, like when they start diagnosing, it is between 20 to 40 mostly.
And
those are the reproductive age group of females also come with anemia in the same
right.
age.
So these are known risk factors for anemia. They are associated with hypothyroidism, and more importantly, they are not on the causal pathway. Hypothyroidism will not change the age or the sex of the person, right? So safely, for many of the associations, age and sex are a priori confounders. So I think this is my last slide. I want to really thank Dean of our institute who has given me formal permission to conduct these sessions. My department, which has always stood by me, supported me, my PGs, many of whom are attending this session, as well as my faculty, and Dr. Prashant Thoward, who has been kind enough to share the research question and to share his ideas, and the heads of the departments and all the faculty members who are involved in the reporting from the Department of Medicine, Emergency Medicine, Pediatrics, Pulmonary Medicine of our institute, the Central Pollution Control Board, and of course, the coordinator who sets the stage and designs the flyers and is really doing a great job with the coordination, Dr. Sumana Mukherjee, whom also I want to thank wholeheartedly.